Hello and good evening to everyone. My name is Fahim Shakur, and along with my co-host Mehran Javed, welcome to another episode of Med Talks Live, streamed on Facebook Live along as YouTube and on Awaz 103.1 FM Pendle FM. This evening, we'll be talking about substance misuse and addiction, a very interesting and topical subject for which we've already had many questions come in. The actual topic today is quite serious, and for those of you who may have issues with some form of addiction, it's worthwhile telling you in advance about a good website called talktofrank.com, talktofrank.com, and the phone number is 0300 123 6600. I repeat, 0300 123 6600. Obviously, if any of these issues do affect either you or someone you love, then those are very important resources, and please do bear them in mind. Without further ado, Mehran, to introduce our special guest tonight.
Thank you so much, Fahim, and hello and welcome everybody for another episode of Med Talks being broadcasted live on YouTube, as well as our usual radio show on Pendle Community Radio Awaz 103.1 FM. So today we would like to welcome Dr. Cyrus Abbasian, who is a consultant psychiatrist and addiction specialist, to discuss the issues around substance misuse as well as the very broad topic of addiction. So he's a consultant who has MBBS MSc BSc and MRCPsych. He completed psychiatric training at the Maudsley Center of Excellence. If you're in the psychiatry field, that name should ring true. So he's been very influential around this topic around the world. So we'd like to really be grateful for Dr. Abbasian. So I guess for the purpose of this, is it okay if we call you Cyrus?
Yes, please.
So thank you for coming on, Cyrus.
Thank you for having me.
Great. So I guess the topic itself, substance misuse. When someone hears substance misuse, what should they understand by those terms?
Okay, so when I assess someone for the first time, I want to know exactly what they're taking. And what I do, I take a 7-day history from them. So I want to know what they've taken exactly in the preceding 7 days, whether it's drugs, or it's alcohol, or anything else. It could be even over-the-counter medication. I've had patients who are addicted to dihydrocodeine you buy from your local booths. Yeah. So really good, accurate history is important. Broadly speaking, we have 3 types of drugs. We've got the uppers, the downers, and the hallucinogens. The uppers would be stimulants such as cocaine, such as amphetamines. The downers would be the alcohol and the opiates such as heroin. And the third group are the hallucinogens like PSP and LSD, which used to be a magic mushrooms. They used to be popular once upon a time. Now, there's a difference between sort of taking a drug just once, abusing it, and becoming dependent on it. And a good example is with alcohol. Alcohol is the most commonly abused drug in the UK. And it's in fact the most damaging drug that we have. Up to 2 million UK citizens could have alcohol dependency, addiction to alcohol, which is very serious. Now, most people have a drink in the evenings, at weekends, and they're within 14 units, as recognized by the government. The abusers, sorry, I think my Sirius just gone off. Sorry, let me just switch this off.
Sure.
That's what a live show is all about. It's okay.
Yeah. To one side.
Yeah.
Okay. Right. So with alcohol, we have the sort of the hazardous drinkers, the harmful drinkers, and the addicts. The hazardous drinkers would be like the typical doctor or a medical student, when they go on a bender at the weekend and drink a lot over on a Friday night, and they could throw up, they could fall over, crack their head open, so they put themselves in a really risky situation because of it. Then there are harmful ones, the ones who drink, say, 1 to 2 bottles of wine every evening. They're functioning well. They may be going to work, they have a family, no forensic problems, but then one morning they turn up, they're in liver failure, because there's that gradual harm that's building up in the system. And then at the extreme end is the addiction. So people who need to have a drink first thing in the morning, an eye opener, otherwise they cannot function, they cannot get going. And then sometimes they have to drink throughout the night just to feel normal. So that's the very extreme end. And as an NHS doctor, we usually we treat quite severe addictions, alcohol and heroin usually.
So would you classify tobacco as a substance? Because I guess a lot of the evidence is that, tobacco and alcohol probably have the most impact in terms of public health. Would you say that?
It's extremely addictive. So in terms of public health, probably it comes 7th in terms of the damage it does to us, to UK citizens. Now, when you smoke tobacco, you don't become intoxicated, you don't get into fights as such, but it causes damage to you physically. And ultimately, we have the NHS here. So it damages people's taxes. People pay for the NHS as a health insurance. And then someone who's smoking is overusing NHS services. There's no benefits associated with tobacco smoking whatsoever. It's only harmful. And both alcohol and tobacco, if they were relatively new drugs, by new drug, I mean heroin came from China initially and Central Asia, cocaine from South America. But whereas it's sort of tobacco plantations in North America and also alcohol has been brewed in the UK for many centuries precedes that, because it's culturally ingrained. Otherwise, both tobacco and alcohol would be illegal now. And going back to tobacco, passive smoking is a big problem. Although thankfully we can't smoke in clubs and indoor in public places anymore. It can cause a lot of damage to someone who's not a smoker. So yes, tobacco is very damaging. Thankfully, we've seen gradual decline of tobacco misuse in the UK and across the globe. Well, in the developed world, really. In the developing world, it's either going up or remaining static.
Yeah. Fahim, you're about to say something?
Okay. Yeah. Cyrus, I was just saying about, in terms of addiction, I mean, is it considered a habit or not?
Okay, so habit. I mean, what's a habit? I mean, someone who's got a hobby, they could go cycling 2 or 3 times a week, and someone's got a habit of, I don't know, collecting little miniature cars, or, addiction is not a habit. It's very serious. And a lot of people who've got addictive disorders, they're in denial. They dismiss how unwell they are. They blame others and think, oh, don't blame me. I know how to control how much I'm taking. It's always the neighbor's fault, fault or somebody else's fault. So usually someone who says to me, oh, my drinking or my drug intake is only a habit, I get really suspicious and worried. And I need to quantify exactly what they mean by that.
For someone to
follow up
addicted.
in terms of addiction,
Go on.
Yeah, in terms of the root causes, I mean, what would you say it is? Genetic, environmental, or what would you say, Cyrus, in terms of the actual causes?
Yeah, so a very good question. It's a combination of both. When I was a medical student, I was more in favor of the environment and how much an influence that can have in an individual. So we have communities in the UK, for example, where alcohol is readily available, but within that culture, it's frowned upon, and we have less levels of alcohol dependency within those communities. So cultural setting is very important. Also, that genetic predisposition can put these people in a high risk category to become addicts. Also mental health conditions. There's a concept called dual diagnosis, whereby we have a mental health condition and addiction as well. For example, someone could have general anxiety disorder. They feel anxious all the time, and they drink to treat that because alcohol is a depressant, And after a while, what happens to them? They develop alcohol dependency as well. So the environment is important, culture is important, availability is important. So public health measures. Everyone's talking about COVID-19. We've had an epidemic in this country for many years now, which is alcohol. It's very cheap and very easily purchasable. You can go down any corner shop now and buy alcohol. And a can of super strong cider or lager is sometimes cheaper than mineral water in the same place. It's very strong. So we have alcoholic drinks designed for alcohol dependency. And so in terms of public health intervention, we need to do two things. We need to increase the cost of alcohol. So in Scotland, they've introduced minimum price per unit, for example. And early results indicate that it actually has led to reduction in consumption. And also not have alcohol so widely available everywhere you go. And the Norwegian model is a good one. Alcohol is expensive, and to buy spirit, you only have to go to specialist government shops for particular hours to buy that. And there's two methods that can really control alcohol intake on the societal level.
So when we talk about addiction, we refer to people's, I guess, to some extent, their behavior, and they may have adapted to this kind of behavior for a period of time. And I do wonder whether there's certain drugs are maybe seen as a gateway drug to something more potent. And perhaps, do you find that, some people will say, let me try it once, or let me try it a few times. Are there some drugs that are a lot more addictive compared to others?
So yes, certainly some drugs are a lot more addictive than others. Tobacco and alcohol are right at the top, two legal drugs. They're both highly addictive. And I've seen this swap of addiction in many patients. So actually, I had one patient who was addicted to every drug imaginable. So they would have treatment for heroin dependency, they move to alcohol. You treat alcohol dependency, they move to cocaine. And also behavioral addictions. And he became a gambling addict at the end of it. So he wasn't using any substances. So it just shows how much the hardwiring in the brain and genetics is important and relevant here.
So what kind of changes, cerebral changes, do you, because we all, I'm a psychiatrist, but I'm more the old age psychiatrist, and we still do, it is an area that actually needs a lot more focus and attention, because there are elderly people who unfortunately do fall in this category, majority being alcohol or tobacco. What kind of changes in the brain would you see with someone who's been classed as suffering from substance misuse? I guess it depends with which kind of substance, because they all have slightly different effects on the brain. But what can it do to your brain?
So regarding the elderly, we think they're very much a hidden population. So it's something that a generalist or a GP is less likely to focus on, because we have these stereotypes. The typical drinker we don't think is likely to be an elderly woman. But yeah, they could be drinking 1 to 2 bottles of gin every day without telling people. And also, just before I answer your question, in Asian communities as well, I did research that showed that practitioners are less likely to ask Asian patients whether they drink or not, because there's an assumption that for cultural reasons they don't drink. And what happens is a big problem in Asian communities, and it's very much hidden because there's a lot of stigma associated with it. A lot of Asian patients that have had it presented late as a result and in a much worse state, whereby if they had acknowledged as a problem early on, it could have been dealt with earlier. Regarding the damage to the brain, so the damage is both indirect and direct. And interestingly, the indirect damage in the form of malnutrition is the bigger one than the direct one. So as a doctor, you've heard of Pabrinex, which is basically vitamin B. And someone who is, if you're drinking, say 8 pints of beer a day, you don't have much appetite for anything else. That's not a healthy, balanced diet. So you actually become malnourished. You get a lot of calories, you get a beer belly, but some of those essential vitamins that the brain needs are not there. And it can lead to permanent brain damage and permanent amnesia. So you're in this kind of state of forgetfulness all the time because of the brain damage. And there's sort of, we could have a fall because of intoxication. So the trauma to the brain, to the head, could damage the brain. You could have a withdrawal seizure, again, that could cause damage to the brain. And the alcohol itself directly can kill neurons. And if you imagine the brain is floating in this fluid, and if you add alcohol to it, well, it's gonna damage the external surface of the brain.
Excellent. I want to just change tangents. There's so many drugs out there to discuss, isn't there, Cyrus, tonight? And alcohol's bigger, but we had a lot of people asking about cannabis. And in particular, can you tell us, is there any correlation from the research you've read or know about and with cannabis and mental health problems at all?
Okay, very topical, especially because now doctors can prescribe cannabis. Now, the risks associated with cannabis is much lower than alcohol and tobacco. That's been established. And in fact, because it's illegal, it's made illicitly, and the illicit cannabis is more damaging than if a proper manufacturer would make it. And so the person who smokes it knows exactly what they're taking and what the THC and CBD amount is. And for historical reasons, cannabis is now being made legal, and it still is illegal, although I suspect in the next 5 years it won't be. We'll be following the Canadian example, and the whole of Europe will be. In terms of damage, when the brain is developing, if someone smokes skunk in particular, which is very strong, between the ages of around 14 and 17, then it increases the risk of schizophrenia or psychotic illness 2 to 3-fold. And some people are inherently predisposed to become psychotic, which is losing touch with reality because of cannabis, especially skunk, which has got a lot of THC. So in our clinic, we do see a lot of patients who have schizophrenia, and they have a problem with cannabis misuse as well, which could be, cannabis addiction. And we do get these sort of revolving door patients who get well on the unit when we admit them, but as soon as we discharge them, they start smoking cannabis and they relapse straight away. Having said that, many people smoke cannabis. Up to 1 million people annually in the UK smoke cannabis, but the A&E departments are not flooded by people who are cannabis misusers. It's mainly sort of alcohol misuse problem that presents at the A&E on Saturday night.
Of course. And just as a follow-up to that, to parents who might be listening tonight who've got children or maybe teenagers who perhaps are indulging in cannabis use or are addicted to it, what advice would you give them to try and help their children?
So the first advice is don't panic. It's not uncommon for teenagers to experiment with drugs. Certainly the harms associated with cannabis is relatively low compared to other drugs. Sometimes it's good to have this open discussion with your child to find out exactly why they're smoking cannabis. It's important to be non-judgmental. It's important not to shout at them. Don't sort of punish them for what they're doing, because teenagers are rebellious by nature. They will just smoke even more, and they may move on to taking harder drugs. In an ideal world, yes, there will be no drugs, and there will be no alcohol, no tobacco, and we would have no need to take these drugs. But there is that experimental age that we all go through, and a lot of people do use marijuana. And I hope that one day when it's legalized, then people who are experimenting, they buy it legally and they know what they're smoking rather than the skunk that we get currently.
So I think South Africa banned tobacco, didn't they? And I think they actually ended up having to kind of make a U-turn on that decision. I think I'm not too sure what steps they took before they made that next step, but certainly I think people in different parts of the world have got an appetite to try and curb this, and one of the options is to just outright ban it. But as you said, there's certain other steps one should have to think about, whether it's about unit pricing or decriminalization of some of these drugs, which is something other people have talked about. I think Portugal have done something along those lines. And I think they seem to be a European leader. I'm not sure whether that's entirely correct, but certainly they seem to have a grasp. I don't know what your experience is of that, Cyrus.
So when you decriminalize a drug, it means that if you have some for personal use, then you're not punished. Because according to the law, taking drugs is illegal. You could go to prison just because of you smoking cannabis. But the reality is that you can't arrest and imprison 1 million UK citizens every year because of smoke cannabis. And so the police go after the suppliers. And if you possess with intention of supplying, then you're in serious trouble. Whereas if you're caught with a small amount personal use, you could get a caution. And addicts, it's often unhelpful to put someone in prison who's got an addiction. And often what happens, they get a community order that they have to sort of serve their sentence in the community, so to speak. And they have to go to a treatment center for a period, and they have to produce evidence, clean urine drug screen, for example, to show that they're actually not using that substance. And the judge will tell them, okay, I know you have a problem, you're committing crime because you're an addict, but if you sort yourself out in the next 12 months, you won't go to prison. Otherwise, I won't have a choice but to stick a custodial sentence on you.
Yeah. Because it's interesting, because in South Africa, I keep going because I just find this situation quite fascinating, is those people who couldn't actually buy tobacco found themselves interacting with drug dealers, and then subsequently they were exposed to other drugs in addition to tobacco. So it's, there are consequences of certain things.
Now, I mean, because of the lockdown in South Africa, what they did, they banned alcohol because of domestic violence. I think that was the reason. Yeah. Because it's a big problem there, and if you're in lockdown and you can't necessarily leave and get help in a violent household, and if you add alcohol to it, then it's really throwing fuel onto the flame. I think that's the reason it was banned, and I don't understand why tobacco was banned for a period. It could be because the off-license sell both. They couldn't be open just to sell tobacco and not alcohol. Maybe that's the reason.
Okay. Cyrus, in terms of obviously what you've been describing, all these different substances, from what I'm hearing tonight, alcohol to you is a bigger problem to society than maybe the other drugs. So I guess the audience will be wondering, so what do you think about the legal rules to do with the different drugs? Some are class A, B, C, some are legalized drugs. I mean, where would you draw the line? And do you think as a society, we're going to be having a discussion on this?
Yeah, I mean, a very good question. And it's historical, really. This kind of war on drugs. The history is really interesting because it was Nixon who initiated the war on drugs. And at the time, the Vietnam War was raging, and he disliked Americans, youth, taking drugs and going to festivals. He wanted them rather going to Vietnam and fighting the war. And so this is why he classified a wide variety of drugs as illegal, and then the rest of the world sort of followed the example. For example, LSD is very different to cannabis, is very different to heroin. And alcohol that's so damaging is legal. So it doesn't make sense. And David Knott has done, he's a professor of psychiatry. He's done some really good research here. And his main study was published in The Lancet a few years ago. And in terms of head-to-head studies, if you have one person with alcohol dependency, one with heroin dependency, the one with heroin dependency has a worse prognosis. So the most damaging drug we have out there is heroin, followed by cocaine, especially crack cocaine. And alcohol comes about fourth. But then if you add in prevalence data, which is how much this drug is used in the population, then alcohol is right at the top. Because a lot of people drink, and 1 in 4 people drink too much. Whereas with heroin, there are less than 200 heroin addicts in the UK who inject heroin. So the numbers are much lower.
And in terms of getting help for this, obviously, because of the legal ramifications, perhaps it can make people reticent to seek help. At the beginning of the show, I did mention talk to Frank, but there's so many ways to get help, isn't there? Through the NHS, private sector, charities, detoxification. Can you tell us a bit about the avenues people can get help for an addiction, Cyrus?
So all GP surgeries and all boroughs in London, all councils in the UK are linked to an addiction service. So there is definitely something there. And a lot of these places accept self-referral. So you don't have to go to your GP to be referred to them. And also they have, so they're staffed by health professionals, doctors, nurses, addiction workers. So if you go there with a heroin addict, they're not going to call the police and say, oh, this guy is breaking the law. They see you as a patient and treat you as a patient. So you don't have to worry about it. Just it's important to get help, and to get help early. Because addiction doesn't have a happy ending, unfortunately.
Some of the comments we're receiving, there's a message from a gentleman called Sohail Patel. He's talking about can denial be used to protect one from potentially taking ownership of negative consequences? And as soon as one admits, does that mean that the weight of responsibility lies on their shoulder? I guess we've both kind of come across these kind of scenarios. But what's your take on ownership, as well as perhaps means of managing distress where denial may be certainly a factor?
Denial is a big factor. And this is one reason that at AA meetings, one of the things they do, they introduce themselves and they say they're an alcoholic, because it has to remain as a reminder to them that if you're an alcoholic, you'll always be an alcoholic, even if you've been abstinent for many years. I've seen patients who have relapsed after 20 years of abstinence, because the brain changes because of addictions and never gets back to how it used to be before the individual started using the substance. So denial is a big barrier, sort of that kind of pre-contemplation phase, whereby they don't even accept they have a problem. And there are therapeutic approaches that they can move into contemplation stage and take those few steps into getting help and into ultimately recovering. And health professionals do have a duty to tell patients in a non-judgmental, empathic manner that, listen, you're drinking too much, it's difficult to accept, you're causing damage to your liver, here's a leaflet, go and read about it, get help. And those few moments could actually turn someone's life around, and suddenly the penny drops that, oh yes, I'm in a hospital bed because I was drunk and I fell over, and they come out of that denial.
So he may, I guess, and he's left it quite open, but one of the things he could be alluding to is about the criminal system, criminal justice system, about responsibility, and about whether you should bear the weight of the consequences of something that might have happened whilst you're under the influence of A or B substance. What's your take on that?
I mean, as far as the law is concerned, it's not a defense in court. If you drink drive, you can't say, "Oh, sorry, Your Honor, I was so drunk I can't remember what I was doing." Yeah. It's not,
there's that concept of diminished responsibility, but I think it doesn't fall in those kind of scenarios that you've talked about. So I agree with that.
So ultimately, it's the judge or the jury that make that decision in a court of law. It can be a bit tricky if someone's got dual diagnosis, so they have a mental health condition and they use drugs to treat that mental health condition. Because having a mental illness can be a defense in court. So if you're sort of hearing your voice and you can stab someone because the voice is telling you, because the patient, you have psychosis, that can be a defense in court.
Okay. Yeah. Cyrus, in terms of for the audience and maybe trying to get help for people, are there any observations they can make from other people to see if they've got an addiction of some kind? Is there any general advice you can give as to the alarm signs or warning signs, things to spot in people?
A change. Often sort of relatives and loved ones realize that there's something not quite right here. There could be smelling of alcohol, or they could find, the parent could find drugs on them. They could wake up late in the morning because, they can't sleep at night because of taking stimulants. They could have got into trouble with the police, could have had falls. So the presenting symptoms can be quite wide, but there's a change. And there's that kind of social decline in terms of they skip school, they skip college, they don't go to work, they don't meet up their friends like they used to. So something happens.
Okay. And in terms of personality, we know about things like impulsive personalities and other types. Are there any that predispose to having an addiction of some description, or is there no link to the personality type of the individual? Yeah.
So there is, for example, someone who's got ADHD, attention deficit hyperactivity disorder. That kind of hyperactivity is also linked to impulsivity. And so there's a strong correlation between ADHD and substance misuse. So these people don't think through properly regarding the consequences of what they do. And also sometimes they treat their symptoms with drugs that can lead to addiction. So impulsivity is an important factor. Conversely, if you're a bit of an introvert, a bit paranoid, maybe we all have a friend like that who doesn't do anything because they're so scared. Doesn't stay late at night, doesn't take any alcohol, well, you're not going to become addicted to anything because you're just so scared of all drugs and people and everything.
So we've kind of touched on the criminality or possible decriminalization and what that actually could mean. What are the other avenues of trying to actually improve the outcomes? Because unfortunately, people that do find themselves being under the influence of substances, they tend to be from deprived areas. They tend to be from areas where there's lots of health inequalities. It almost feels as though we're always talking about the same topics in the background, which seems to be driving these things. So how do we improve treatment? How do we improve outcomes?
Okay, so recovery is important. So it's important not to only treat the addiction, but give something instead of addiction to the patient. It's not difficult to detox, say, a homeless person with alcohol dependency on a unit. But what do you do after 2 to 4 weeks of treatment? Well, what do they go back to? If they go back to the street, they're going to start drinking again. So a lot of investment needs to go into patients who've got addiction. And that inequality is a major factor. And one worry that I've had, and a lot of psychiatrist colleagues had subsequent to the COVID-19 shutdown, was this kind of economic damage it will cause. And that could lead to a second wave which is going to be worse than the initial COVID-19 wave in terms of mental health issues and drug and alcohol misuse problems. And there's a lot of strong data, especially from former Soviet Union after the breakup, of correlating alcohol misuse in particular and economic damage to a society and depression, unemployment, and all that. And we need to all mental health conditions, not just addictions, are more likely to affect people from disadvantaged backgrounds. And ultimately, we need to narrow the gap between the advantaged and the disadvantaged.
And I guess the second area is about reducing harm. One is about educating, and there may be various drugs, how to use it safely as a means of actually coming off the drug itself. But during those periods of treatment or changes in their behavior, they can sometimes relapse and unfortunately end up causing more harm than they perhaps would have when they were actually on the drug before. So how do we reduce harm of some of these drugs?
So all patients need to have a relapse prevention plan in place. So if after a period of abstinence they start using the drugs, there's like a safety plan in place, and it can be nipped in the bud before it gets any worse. So a lapse doesn't become relapse. And I forgot your first question, sorry.
I can't remember myself. So it's just, I guess I'm just thinking out loud, because there's lots of suggestions or proposals whether people need, drug consumption rooms, for example, as where
harm reduction. Okay, harm reduction.
Yes. Harm reduction.
The concept of harm reduction is really relevant to psychiatry, to addiction psychiatry. So giving patients methadone instead of straight heroin is harm reduction. Giving them needles, clean needles to inject with, it prevents blood-borne viruses. That's harm reduction. Medicinal cannabis that doctors can prescribe now in the UK can be used as a form of harm reduction. So if someone is smoking 500 pounds worth of cannabis every month, it's much better for me to give them medicinal cannabis than to say to them, okay, just carry on smoking, street cannabis. I'm not going to help you. So it's a very important and a valid concept. So we tell someone who misuses drugs is that, okay, I know it won't stop. I know you're not ready for that change yet. But in the meantime, let's reduce the harm associated with it. And in some clubs, they've got kits that they test ecstasy tablets and whatever pills the person buys, they can just test it and before swallowing it. So that would be harm reduction.
Great. Cyrus, with time pushing on, I do want to take some questions from the audience. We've had many coming through as the show's been going on. And it goes back to what you were saying about Nixon and the war on drugs, actually, one of them. And they were saying, what does Dr. Cyrus think of the opioid crisis in America? Quite a broad question there for you, Cyrus, but could you address some of that maybe? And is it actually relevant to the UK?
Well, it's drug companies that have operated like drug pushers and drug manufacturers and drug dealers. And it's a huge problem in America, and only in the past few years they've realized how problematic it has become. OxyContin, for example, abuse is tragically common in North America, and it can not only lead to addiction but overdose and death. So what kills an opioid addict is overdose rather than others. So that's the commonest reason of death, because they have respiratory depression because they take too much of the stuff. And it hasn't been as problematic here, thankfully. And we have to be really careful. And I teach a lot of junior doctors and medical students, and what I tell them is that whenever you prescribe any medication, think about its ability to cause addiction.
Mm.
And also, I know pain specialists who have moved away from opiate analgesics altogether.
Mm-hmm.
You know, pain is a natural phenomenon. I mean, we should try and tolerate and put up with pain as much as we can. And this kind of opioid analgesics should be given for really severe cancer pain or short-term pain relief or end-of-life pain, and not just as for chronic ongoing pain, because it leads to addiction. And in the long term, it worsens the pain. It not only doesn't get rid of the pain, it worsens it, and it could lead to overdoses and dependency to other drugs even.
And linked to, I guess, the concept of addiction that you said and common drugs, especially in the lockdown, I think some people may have noticed more people asking for sleeping tablets from their doctor. And obviously that can be quite addictive. Can you just tell the audience a little bit about why many doctors try and avoid prescribing sleeping tablets, the effect they have long-term, and maybe some natural alternatives?
So the brain is a very complex organ. If you believe sort of our neuroscientist colleagues, it's the most complex organ in the universe. And so it's often just one tablet is not enough. You know, we have this whole holistic care of our patients, and we apply the biopsychosocial model, and the biological bit is just the medication. And as a rule in psychiatry, if a medication works immediately and works really well, it's likely to be addictive, such as benzodiazepines, sleeping tablets, such as Z drugs, such as zolpidem or zopiclone. Now, in the short term, yes, if someone is in a lot of distress, they haven't slept for several nights, I would give them some sleeping tablets just to help regulate the sleeping pattern. And I tell them that, you're not getting any more. Just 1 week. Take it if you absolutely need to. But then once your natural sleep comes back, you have to stop taking it. So short-term use only with sedatives, which includes diazepam, lorazepam, Xanax, which I don't prescribe at all, we shouldn't prescribe at all, or the Z drugs. In terms of natural remedies, sort of CBT, which is a type of therapy, cognitive behavioral therapy, is the most effective treatment we have for insomnia. And a lot of people who don't sleep well at night have just got really bad habits. They smoke at night, they take a lot of coffee, they play computer games, their routine is terrible. And just to regulating that, the sleep hygiene methods can be the most important thing for them to help them sleep. It could be because of some kind of physiological problems, because of apnea, because they can't they stop breathing basically when they sleep, and they wake up as a result. So maybe they need to see a specialist for that. In terms of an antihistamine, I recommend, you can buy it over the counter. It's called promethazine, and it's an allergy tablet which at high doses can cause sedation. It doesn't work as well as the Z drugs or benzodiazepines, but it can be good as an intervention to help people sleep.
I think you've touched on an important point about sleep hygiene, isn't it? How much we can optimize our sleep without resorting to pharmacological methods. But if people do find themselves in that kind of situation, obviously, pharmacists are on hand to discuss that situation with, as well as your own GP. So please do seek that advice. We are getting some more questions. Another one was around the BME community response to addiction. Is it still very much hidden? Is there a lot of stigma, and how do we address the issue around addiction? Because they can present in different ways, can't they? Whether it's emergency services or in the community.
I think as practitioners, we should always ask all our patients whether they drink or whether they take drugs. It's one of those questions that you have to ask. Don't just assume, oh, this chap is 70 years old and South Asian. He's not going to drink, is he? Well, how do you know? Similarly, you could have a lot of female drinkers there. So you don't make any cultural assumptions when you see a patient. And a lot of people from sort of BAME backgrounds are missed as a result, because alcohol misuse is thought to be mainly a white problem. And also, a lot of patients present to their GPs for the first time when they have a problem like this, but they don't say they drink too much. They talk about having had a fall or having anxiety symptoms. So talk about a related symptom. And the GP should pick this up and then ask about alcohol or drug intake. And usually when the doctor asks, or any professional asks, then the patient is willing to disclose that yes, they're drinking too much, they're losing control, and they want something to be done about it. And with the families, I mean, it's important not to be embarrassed and ashamed. And as someone who's got an addictive disorder, they're a patient, and they should be treated as a patient, like anyone with any neurological condition, like epilepsy or any health condition even. By sort of being angry at them and blaming them. I mean, the addiction is a disease, and someone who is at the end of the spectrum, at the severe end, they cannot stop. This is why they carry on drinking, and they just cannot stop. They lost control, and that really defines what addiction is: losing control.
I think some families sometimes go down a very hierarchical approach to managing difficulties within the family, and you know that there is that different relationship, or that means of addressing the issue, isn't there? And I think that, as you said, you know, pride is important. I think pride does maintain and does have a place in terms of standards, etc. But sometimes it can seriously have a negative consequence on someone's health and well-being. So everything in moderation, I guess.
Yes, everything in moderation, and as low as possible, ideally.
Yes.
Cyrus, in terms of sports and exercise, I want to touch on that before the show ends. That's obviously a key part of good health. And what's the link with that in maybe helping with addictions or psychiatric mental health? Is there any link with that, alleviating those problems?
I mean, well-being is so important, especially with the current lockdown that we've experienced. And with all my patients, I just talk about it's important to have a proper weekly schedule, to exercise every day if you can, have a healthy, balanced diet, don't work too hard, sleep well, eat well, go take regular holidays, and just look after yourself, and just look after your brain. And exercise is an important component of that. And I mean, we were not designed to sit on a chair in an office. You know, we were designed as hunter-gatherers. We were designed to just run everywhere and to gather stuff or hunt animals. So it's kind of this sedentary lifestyle is really damaging to our health and well-being. It's important to move and to be active as much as possible.
Okay. And in terms of diet as well, are there any particular foodstuffs that may be helpful in these sort of things? I mean, there is some research about the keto diet with epilepsy, but just broader in terms of helping with mental health, addictions. Are you aware of any particular food groups or things that people can look into?
Plenty of fruits, vegetables, and fish oils. I mean, just a healthy, balanced diet, as you would advocate to anyone. There's some evidence that omega-3, the fish oils, can be a little bit more advantageous to someone with mental health issues. But at the end of the day, if you have a healthy, balanced diet anyway, then that's the most important thing.
Cyrus, there may be some listeners or viewers that are in a situation that, you know, that we're covering, or they know of someone. What kind of positive journeys could you mention so that they can actually feel motivated to address this issue?
So obviously, don't give up. There's always hope, and get help early. The nature of the condition is that it is a relapsing remitting condition. And a lot of people do relapse a number of times before they realize that they have to be abstinent. A lot of people present late because they're in denial or they're ashamed or whatever. So my advice would be to get help and get help early and stick with the treatment plan. Listen to what a practitioner tells you to do. You can, go to AA meetings, you can go to NA meetings. There's so many meetings you can attend. You just learn from your peers regarding, because these are the people who've been there, they've done that, and listen to the story and learn from them. And also there are a lot of online forums now. There's via Zoom, you can, join so many groups now. And all the information you need, you can access it online as well.
Great. No, I think we're also running swiftly out of time. Time has flown by as typically as it does. We usually tend to ask our guests for 3 tips for ensuring that, in terms of substance misuse or ensuring that the concept of addiction, because we haven't actually covered gaming addiction, which is another field in itself. But what kind of tips would you give the listeners to ensure that the health and well-being is optimized?
Well, the first tip is don't take any illegal drugs. I know it's easier said than done, and I know that the teenagers there who want to experiment, and their youth culture's there, and it's difficult for them not to belong to a peer group unless that they have experimented with drugs. And if you want to use something, try and reduce the harm as much as possible. Because even drugs such as ecstasy and amphetamines, they have contaminants mixed in with them. Because they're usually made in some dodgy basement. So it's that could irreparably damage you. With alcohol, again, either very low or 0 or in moderation. And just keep just calculate how many units you're drinking when you're out, and keep a diary to make sure you don't go above government levels. And the final tip I've mentioned already: if you need help, get help early. And most addiction services are highly professional and confidential, and they will respect your confidentiality. They won't arrest you, they will help you.
I think that's very supportive to reinforce that point, Cyrus. Some of the listeners are also asking if there's any book recommendations you can give, Cyrus, for the general reader, Joe blogs on the public to learn more about this topic. Are there any good reads that you recommend?
I don't read books anymore. Sorry. The last book I read, I think, was 20 years ago.
This is actually for him. This is actually for him trying to find out for the book club.
Yeah, I know. We do a book club, so I was trying to get a book for that, but okay.
You won't see me there, unfortunately. Maybe Tweet Club, or that might be more appropriate for me.
No, that's great. And obviously we talked about moderation, just to sum things up, Cyrus. But I think the word addiction is used quite loosely in the English language, isn't it? He's addicted to this, she's addicted to that, or this or that. What do you think? Do you think that's made it harder for you as a professional with the way it's used in the modern day world, or it's not made any difference the way the word addiction is just bandied around?
Well, it's our role to figure out exactly what a patient means by addiction. And often someone who comes to me and they believe they use the term addiction, they actually don't have an addiction. And it's the ones who are in denial and they don't really want to accept they have a problem are the ones who've got addiction or dependency, which is used in a similar fashion. And a lot of stigma associated with the word addiction. And this is why it's not used very often. And people are scared to come forward and say that they're addicts. And so maybe dependency would be a more acceptable term to be used.
Okay. And just as a last thing, as we run out of time, I know we've talked about culture and other things can sometimes be negative in terms of stigma, but conversely, what about, is there a positive impact of culture and religion in trying to prevent addiction at all, or not?
So yeah, I mean, in cultures whereby drinking is not accepted and is frowned upon, is much less likely to lead to problems.
Mm-hmm.
But doesn't mean it doesn't exist. It could all go underground and could become secretive. Also, in some cultures, children are exposed to alcohol at a very young age. So the mystery surrounding drinking then disappears, and they learn how to be sensible drinkers and not to binge from an early age. So in sort of Southern European countries, sort of the Mediterranean way of drinking is quite different to Northern European. So Southern Europeans drink a hell of a lot, but they keep the blood alcohol concentrations low, and they drink small amounts throughout the day, which causes less harm than if you binge on a Saturday night and you drink the equivalent of what you should drink in a week in just one evening.
Quite sobering thoughts to finish the show on, would you not say, Mehran?
Yeah, no, I agree. So it's, there's a host of things we've covered, but I guess the key is not to suffer in silence, and as healthcare professionals, always probe and ask, the right questions, especially at the right time. Fahim, we've got a stellar lineup for next week.
Yep, we've got Dr. Enam Haq, GP from the Manchester area, and also Dr. Saima Iqbal as well, who's also featured quite widely on national television as well, and came on a few weeks back earlier. And we're talking about racial equality. We're going to be talking about the BME experience. We're going to be talking about Black Lives Matter as well, and so many other things of that nature next week. Really looking forward to it. And I'm glad you mentioned, Cyrus, about domestic violence. We covered that last week, so thank you for mentioning that. So yeah, very important topic, but we have already got that for listeners and viewers. That's on our backlog of schedule. It's available. So Cyrus, I just want to thank you again for sharing your time. It's been great to have.
Thank you for having me.
It's great. So hope you're well. Stay safe.
You too.
And to all our listeners and viewers, hopefully see you again next week on Tuesday, 8 o'clock.
Thank you. Thank you, Cyrus.
Thank you. Bye-bye.